Can we start now?
Yes, ma'am.
Just a minute. Konnichiwa, thank you. Thank you. Sorry, I was giving YouTube live.
It's live now. It's there.
It's live now. It's live now. Yes, thank you. Thank you. At this outset, I welcome you all for the 9th edition. We have done almost all the systems. Today we are having two stalwarts from endocrinology. So I welcome Dr. Sridevi Narayanan. Dr. Sridevi Narayanan needs no introduction for IAP Chennai. She is professor, Institute of Child Health, Egmore, and she is also heading the diabetology clinic there. And she is running a diabetology clinic in ICH. She has funding from ICMR, and she is doing a lot of research on pediatric diabetes. So I welcome you, madam, a long-term friend, Dr. Sridevi. Then we have Dr. Hemchand sir. Dr. Hemchand sir is a pediatric endocrinologist, consultant from Mehta's Children's Hospital. Then we have our mentor, Dr. SBS sir. SBS sir is here to guide us for this. Sir may leave in the middle for a national meeting at 9. I hope he is there till that time. And we have our president, Dr. Somsundaram sir. Welcome you, sir. So our presenter is Dr. Asima, my PG. She is from SRM Medical College. So I'm happy that one of my PG is presenting today. So let's see, we'll have a very good discussion today. The mentors and the postgraduate have prepared enormously for this program. So without wasting much time, sir, Somsundaram sir, a few words from you.
So, good evening. Thank you, Dr. Prasanna, for your introduction. And so this PG teaching program under the name Gurukulam is under the aegis of our convener, Dr. Balasubramaniam, and under the coordinatorship of Dr. Prasanna and Dr. Nisha is going on fine. So we have almost completed 8 sessions. So we have 2/3. It's done. The last 1/3 is left behind, and today is the 9th session. Major systems are almost done, and we have now popped into endocrinology. So for this, we have 2 people working in endocrinology itself. One is both in the IAP administrative side, Dr. Sridevi, Professor Sridevi from ICH. So she has held many posts in IAP. And Dr. Hemchand is a well-known national renowned speaker and a teacher of endocrinology. Welcome you both on behalf of IAP Chennai City branch. And Dr. SPS sir, as always, the last session was on nutrition, was well taken and well appreciated by most of the viewers. Even in YouTube, we had almost 700 views after the meeting was over. So thank you for your inputs last time, sir, SPS sir. It was well appreciated. So hope this session also with Dr. Prasanna and his postgraduate Azima will be an enlightening session and an enriching one for all the viewers, both postgraduates and the pediatric practitioners. So hope and wishing all a good learning experience for the next 1 to 1.5 hours. Thank you. Over to SPS sir. Anything to say, sir?
Nothing. I look forward to a very exciting session with 2 stalwarts, Dr. Sridevi and Hemchand. I look forward to learning from both of them. Thank you very much.
Yeah. So over to Sridevi. You wanted to start some questions. Yeah.
I thank IAPCCB for the great opportunity, and more so for putting me with Hemchand, who is a very good teacher, everyone knows, and he's been doing major part of the
Our connection is lost.
required inputs. So my job is made easy. So I thank
Sometimes switching off the video will help the audio to be better. Try that, ma.
Sridevi madam, switching off your video will help so that your audio is clear.
Might help. No, I think the connection is lost.
Yes, sir. So, Hemchand sir, shall we start, sir?
Hemchand also, it seems he's offline.
No, I'm here only. I'm here.
Yeah, you are here. Okay. So if you are there, then Hemchand, you can. Yeah, Sridevi is back. Yeah. Sridevi, you can switch off your video if it's right.
I'll switch off my video. So, this is an endocrine topic, but short stature is an important topic for postgraduates. So, we all know the definition of short stature, which the student will be dwelling upon. And but just because it is covered in endocrine, it doesn't mean we don't jump to a conclusion that any short stature is of endocrine cause. We have multiple causes of short stature, right from systemic to nutritional to endocrine to genetic defects. So multiple myriad of causes are there. So what we need, we have encountered different types of patients presenting with short stature. Like to mention one, like I've once seen a child presenting mainly a short stature, but then the child also had pallor on examination, and the BP was in higher centile, and finally turned out to be CKD. So it can be anything. So a systematic approach is essential whenever you see a child with short stature, and that is what we'll be trying to do today. The presenter has done enough hard work, and she is going to start presenting. So I request Asima to take over and start presenting the case.
Yes, ma'am. Thank you, ma'am. Good evening to one and all present here. Today we are going to have a case discussion on endocrinology. Thank you for my mentors, Dr. Sridevi ma'am and Dr. Hemchand sir. Are my slides visible, sir?
Yeah.
Thank you. This is a 5-year, 8 months old male child, informant being mother, reliability good, brought with chief complaints of not gaining adequate height, noticed since 3 years of age. Mother noticed that her child is not growing in adequate height since 3 years of age. He's short and growing slowly when compared to other boys and peers in the same age group. Child used to sit in the first row in the class and noticed no significant outgrowing of his clothes and shoes. Incisor tooth erupted first at 9 months of age, according to his mother. Mother also noticed no behavioral issues, plays well with peers, and interacts well with family members. Mother also noticed there was a relatively preserved weight compared to height. There was no history of decreased appetite, pallor, leg swelling, no history of any fever, weight loss, decreased activity. No history. Yes, ma'am.
Asima, as you tell the negative history, can you tell to rule out what you have asked these histories?
Sure, ma'am. No history of decreased appetite, pallor, and leg swelling in view of ruling out malnutrition, any congestive cardiac failure. No history of fever, weight loss, decreased activity for any history of any acute illnesses in the recent past. No history of chronic diarrhea and oily stools in case of celiac disease. No history of recurrent LRI wheezing for any history of chronic respiratory tract infections, recurrent respiratory tract infections. No history of recurrent fractures and skeletal deformities to rule out. No history of recurrent fractures and skeletal deformities to rule out any skeletal issues like osteomalacia, rickets, vitamin D deficiencies. No history of delayed dentition noticed by the mother. Again, for vitamin D deficiency, any malnutrition, any local oral pathology. No history of headache, vomiting, visual disturbances, and seizures to rule out any pituitary causes or any increased intracranial tension secondary to pituitary causes, pituitary adenoma. No history of constipation, lethargy, excessive weight gain, and dry skin to rule out to get history about hypothyroidism, and no history suggestive of polyuria, oliguria, polydipsia for chronic kidney disease, renal tubular acidosis. Past history. No other history of admissions for systemic illnesses in the past. There was no history of long-term steroid intake or native medication intake. No history of recurrent blood transfusions, and no history suggestive of any CNS insult in the past, such as any trauma, infections, intracranial tumors, or no history of any chemotherapy or radiotherapy to brain and spine, and no history of TB infection. Past treatment history, child was evaluated in ICH for poor weight and height gain at 5 years, 1 month, 7 months back. Basic workup was done there and started on iron supplements. Dietary advice was given for poor weight and height gain. Basic evaluation was done and showed normal FT4 and TSH was mildly elevated. With this results, the child was initiated on thyroxine supplements. Antenatal, it was a spontaneous conception, booked and immunized, taken iron and folic acid supplements. Antenatal ultrasound scans were normal, weight gain adequate, and no history of gestational diabetes mellitus, pregnancy-induced hypertension, fever with rashes, or bleeding per vaginum. Mode of delivery was normal vaginal delivery, term gestation, cephalic presentation with no history of birth asphyxia. Birth weight was 2.9 kgs, appropriate for gestational age, and birth length was not known. Breastfeeding initiated immediately after delivery and no feeding difficulties faced. No history of any neonatal hypoglycemia, neonatal seizures, neonatal hyperbilirubinemia, or micropenis. And the baby was discharged normally on day 3 of life. Development history, the child was developmentally normal, now studying in first grade with average scholastic performance in a normal school. Bowel and bladder habits normal. Child was immunized up to 5 years of age as per national immunization schedule. And child was living in a concrete house, it's a nuclear family. Father is a supermarket manager, mother homemaker, belongs to upper middle class according to modified Kuppuswamy scale. Diet history, the child was exclusively breastfed till 6 months of age and complementary feeding started at 6 months. The expected calorie intake for this child was 1,400 kilocalories per day, but his actual calorie intake is 900 kilocalories per day with a deficit of 500 kilocalories per day, which accounts of about 35.7%. Expected protein was 18 gram per day, but the actual protein intake was 14 grams per day with a deficit of 4 gram per day, accounting of about 22.2%. Family history, child is first born to non-consanguineous parents, no history of short stature in family, no history of delayed shaving in father. Mother attained menarche at normal age around 12 years and younger sibling is 2.5-year-old girl child with an appropriate height for age, and there was no history of any disharmony in family, neglect or emotional deprivation. To summarize, this was a 5-year, 8 months old school-going male child, first born to non-consanguineous parents with uneventful birth history, born appropriate for gestational age, presented with progressive short stature with slow growth rate and relative affection of height more than weight, noticed since 3 years of age, with normal development, dentition, and scholastic performance, with no significant chronic systemic illness. And the child was under regular thyroxine supplements for past 7 months, and there was no family history of short stature and delayed puberty in parents. At the end of summary, my differential diagnosis are endocrine causes, hypothyroidism and growth hormone deficiency. Being the child's height, the predominant concern was height. Second is constitutional delay of growth and puberty, chronic malnutrition, and any other underlying systemic illnesses.
Can you go back from your first slide, Asima?
Yes.
We'll discuss the history. So first of all, this is a 5-year, 8-month-old child, male child. So what is it related to the age? You want to comment anything on the age and short stature? But this child presented from 3 years of age. The complaint has been from 3 years of age. So what is your comment about the age of onset? That is what the mother says.
Ma'am, this can be related with our ICP model. So the child's complaint was started from 3 years of age, which denotes the child somehow had.
Can you elaborate what is ICP model?
Yes, it's infant child puberty model. So at the point of infancy, the contributing factors for short stature are mainly maternal nutrition, any intrauterine factors, placental insufficiency, and hormonally the contribution are IGF, insulin, and thyroid hormones. In childhood, that is between around 2 to 5 years of age, predominantly the growth is contributed by thyroid hormone and growth hormone. And later on in the pubertal stage, it is contributed mainly by the sex steroids and then followed by growth hormone and thyroid hormone. Since this child had an onset of complaint at 3 years of age, we should probably think about the onset in childhood period, ma'am.
Okay. When do these genetic syndromes which present as short stature start presenting?
It can be at birth, ma'am. Sometimes the at birth they can also present as appropriate for gestational age and also can be present as small for gestational age or in the form of IUGR.
Mostly they present at birth or infancy, not at 3 years. So the age of onset is an important point. So that gives us a clue. It could be something related to the childhood onset. That is, could be endocrine or malnutrition or something else. Okay. So next. So we are dealing with a male child. So we are not thinking of which cause of short stature. To put it other way, in any girl child presenting with unexplained short stature, what is that you want to rule out?
We have to rule out Turner syndrome, ma'am.
Fine. So in the history of present illness, you said that the child has relatively preserved weight compared to the height. So what is that you are trying to say here?
The mother primarily was concerned about the height, ma'am, not a weight gain. She was not more worried about the weight gain.
Okay. So you mean to say the child is neither wasted nor is the child obese, because
Yes.
both are abnormal signs. So if the child is wasted more than the short stature, also you think of certain causes. If the child is obese and short stature, you think of certain causes. So you mean to say these two are not there.
Yes, ma'am.
Okay. Next slide. Yeah, you talked about pallor. So how all pallor can be linked to short stature?
In any case of chronic anemia corresponding to hemoglobinopathies like thalassemia, sickle cell anemia, pallor can also be there in chronic kidney disease.
And any chronic illness. You can have anemia of chronic illness. So it can be related in all these ways. What about polyuria? How it is linked with short stature?
Renal tubular acidosis and diabetes,
Yeah, uncontrolled diabetes. So
uncontrolled
that is
diabetes.
again another cause that you have to say. Okay, then go to the next slide. So according to you, there has been no. Why you want to talk about long-term steroid intake?
Steroid intake itself has a direct effect on growth plate, ma'am. So long-term steroid intake can cause early closure of
The known fact that Cushing's causes short stature. And what native medication are you trying to find out here? Any specific native medication? Or again, you mean steroid here or anything else you mean?
native medication corresponding to steroids, ma'am.
Okay. Oh, that is what you're trying to mean. Okay. Recurrent red blood transfusions?
In case of any history in like thalassemia or sickle cell anemia, the child can have recurrent blood transfusions because, and that can itself is a chronic illness, can lead to short stature.
Okay. Next. Okay. You brought out the treatment history. Is the drug compliance good? The child was started on thyroxine supplement. Is the child taking it regularly?
Yes, ma'am, the child is taking it regularly.
Okay.
Compliance is good.
And what about the iron supplements? Were they stopped or they're still being taken?
No, ma'am, the child is still taking iron supplements.
Okay. In spite of the dietary advice, what now, as per your diet history, there is a deficit in the calorie as well as protein. No, that's what you are trying to say. Though the dietary advice was given for this child.
Yes.
Okay. Next slide. Yeah, you said in antenatal ultrasonogram in first trimester, I mean in antenatal was normal. So what is that you want to relate regarding short stature?
We can have signs like any short femur, which can point out to skeletal dysplasias, or any microcephaly in case of IUGR and SGA babies. NT nuchal translucency
Very
and
good.
cystic
So first
hygroma
trimester ultrasound, you will be looking for nuchal translucency. Okay. And in your natal history, what is the single most important thing you want to notice?
cephalic presentation.
Not just that, your birth weight.
Birth weight appropriate for
Birth weight is most important. Okay. There is no SGA or IUGR according to you. Okay. Postnatally, what is the significance of hypoglycemia, seizure, NNH?
uh, can denote to hypopituitarism causes, ma'am, can lead to neonatal hypoglycemia in first year of life, neonatal hyperbilirubinemia and seizures, ma'am.
Okay, next. If this child had a developmental delay, this child doesn't have a developmental delay. If this child has a developmental delay with short stature, what is that you will think of?
Short stature with developmental delay, we can think of all syndromic causes, ma'am, like Turner's, Noonan syndrome, Bloom syndrome, Russell-Silver syndrome. And in metabolic causes, we have to think of any congenital hypothyroidism.
Okay, good.
And
Next
in
slide. So this child, the diet history is still poor. In spite of the diet counseling, there is a calorie deficit as well as protein deficit. But in your summary, you haven't brought it out because this child has got a short stature. And in diet history, you're saying there is calorie deficit as well as protein deficit. So you should entertain give importance to the nutritional cause. It could be a cause because after this, you're going to examine the child and you're going to do the investigation. After that, your diagnosis may vary. But here, given that there is a dietary deficiency, we still have to entertain the nutritional cause being the cause of short stature. Next.
okay, ma'am.
So in your summary, you have to bring it out. What is an important thing in short stature which you have missed out in this family history? Can you think of something which you have missed out? Or you want a clue? What
No,
is the age of the parents? Does it have any impact? Paternal age and short stature, maternal age and short stature.
okay, ma'am.
Paternal age and short stature. Increased paternal age is associated with
Down syndrome.
Downs.
Downs.
That is maternal age, ma. Achondroplasia.
Okay.
Achondroplasia and certain skeletal dysplasias, increased paternal age is associated. So paternal age is very important. And maternal age, again, Down syndrome you mentioned. So both the ages have to be mentioned. That is what you have missed out. Other things you have told. Very clear, very beautifully you have told. No history of delayed shaving in father and mother attained menarche at normal age. And younger sibling also you brought out. According to the parent, there is no concern regarding the height and their height is normal, and psychosocial deprivation also you brought out. There is no marital disharmony, so there is no emotional deprivation. Very good. So that age alone you should have brought out because that is an important factor.
Okay, ma'am.
Next. So in this summary, you have told many things, but you haven't added the diet history. So as per the diet history, the child is getting 35% of less calories and 22% proteins less. So that again you should mention in your summary,
Okay, ma'am.
which you have brought out. So your possibilities.
My first differential possibilities are endocrine causes like hypothyroidism and growth hormone deficiency, constitutional
Okay,
delay.
because this child was a relatively normal child up to 3 years of age. After 3 years, the child has been having short stature as per the mother. And according to the history, there is no history suggestive of any chronic illness which you can point out. So, because of all that, you think endocrine cause could be one of the important cause. Fine. But as per your history, there is negative history for CDGP, no? There is no
Okay.
late shaving, no menarche. You still want to put that as your second possibility, or second and third you want to swap? Because given that in your history, what is ultimately true will depend on your step-by-step approach. Because I feel here you can give malnutrition more importance than CDGP, because in your history you don't have pointer for that. There is no late shaving and there is no late menarche. And systemic illness could still be a possibility, which we should rule out only with examination and appropriate investigations. So only this 2 and 3, there is, my opinion is it could be swapped. Otherwise, good presentation. Over to Hemchand.
Thank you, ma'am. I think we saw a very beautiful child as per history who had onset of growth faltering from the C phase of the ICP model. So she was thinking in terms of the onset of the pathology in the C phase. She pinned the diagnosis on endocrinopathy, but of course her history is giving a beautiful pointer to a possibility of deficit in the caloric intake. So she has put chronic malnutrition as the second possibility. And of course, EDGP, a diagnosis of exclusion. Systemic illnesses, she has not found any significant pointer in the history. So she was probably ruling it out as a possibility. Now, with this background, let us go to examine this child. Over to Asima.
Sir, yes, SB, sir.
Excellent, doctor. Excellent presentation. A few comments. One, you are going by the mother's statement. The whole thing started at 3 years. On what basis? In fact, I'm not happy about your statement saying the whole thing started at 3 years. Was there documented normalcy of height and weight at 3 years for you to say it started only at 3 years? Question number one. Question number two. At no point I heard from you, what was the size of the head? Small, large, normal. To me, that's very, very important in a short stature like this. Third, even an illiterate mother, you can ask a question how the limbs were, how the trunk was, and what was the gait of this child. I mean, these three things, of course, you have not mentioned how the child has been. You have just mentioned development has been normal. If you had mentioned that the limb proportions and the trunk proportions are okay, I wouldn't think of anything like, for example, a contour dysplasia or a skeletal cause for a short stature. Last but not the least, you mentioned incisor teeth appeared at 9 months, but you didn't mention what happened to the teeth development afterwards. More importantly, if you are so sure that the short stature had its onset only around 3 years, you should have produced evidence from your history, either with a statement that the mother felt when compared to neighbors' children, this child was fairly okay in terms of height, weight, everything at 3 years. And then onwards, she noted faltering. Or if she's a multipara, you can always compare with the sibling and say the whole thing was normal at 3 years, then started faltering. And finally, I never heard anything about the height of the parents. To me, that's extremely important. You have put constitutional delay of growth and puberty. The height of the parents, if not the height of the grandparents, I would have definitely mentioned. And in the dietary history, Madam clearly pointed out a deficit. But deficit now, what about the past? First few years, how long was the baby breastfed? When was complementary feeding started? You said baby was normal according to the parents at 3 years. The baby might have suffered from chronic malnutrition right in infancy. Okay. And remember, malnutrition as a cause of short stature is more likely to be a cause only if the malnutrition affects in the first few years, not starting at 3 years. That's extremely unusual. In fact, I would put it as failure to thrive due to some systemic cause rather than malnutrition. If it's going to start at 3 years, malnutrition doesn't arrest growth at that age. And finally, the whole thing can be rickets. You never mention anything about deformities of the child. Absence of deformities, pot belly, double malleolus, and all those things. The whole thing, you didn't put that as a cause for this. It could well be a rickets having its onset by 3 years. So you should have mentioned something about micronutrient supplementation in the diet and the sufficiency of micronutrients in the diet. You mentioned only calories and proteins. I don't think the dietary history is complete unless you talk about the components, whether it is balanced in terms of composition of fats, carbohydrates, proteins, in terms of adequacy of sunlight exposure, micronutrient like iron and vitamin D. My last comment is, you mentioned that they started thyroxine. What was the dose? And what happened to the height after that? How long was it given? Was there improvement or not? I'm sorry for the long list of questions. I'm sure Dr. Sridevi and Hemsad will take it forward. Okay? Thank you.
Thank you, sir.
Thank you for your input, sir.
On general examination, the child was alert and interested in the surroundings. Mild pallor was present. No icterus, cyanosis, clubbing, edema, or generalized lymphadenopathy. Heart rate was 96 per minute. BP was 90-60 millimeters mercury on 50th centile. Respiratory rate was 30 per minute and temperature normal.
So just to reiterate, what is the importance of blood pressure in this short child?
For the blood pressure, we initially have to check the height of the individual, and then correspondingly we have to plot the centiles, BP centiles from the height of the individual. So the importance of blood pressure is...
Does it give you a clue to an underlying diagnosis in any possibility? Madam mentioned about a case which
chronic kidney disease, they
Very
can
good.
have a hypertension.
Very over. Next.
So these are the anthropometry findings. The weight of the child was 13 kgs, lying below the third centile with a Z-score of minus 2.54 standard deviation. Height was 95 centimeters, lying below less than third centile of minus 3.36 standard deviation. BMI was 14.4 kg per meter square on 25th to 50th centile with a Z-score of minus 0.20 standard deviation. The target height from the mother's height and father's height was 156.5 centimeters to 168.5 centimeters with a centile of 3rd to 10th. Mid-parental height was 162.5 centimeters with a standard deviation of minus 1.32. Upper segment is lower segment ratio was 1.06:1 with 25th centile. And from the anthropometry chart, which I will explain it later. The weight age I got was 2 years. Height age I got was 2 years 9 months. And chronological age of the child is 5 years 8 months. From this, it is known that chronological age is more than height age, more than weight age.
I think there's a very, very important message in this slide, and I think this slide kind of sums up the case and helps you to point towards the diagnosis. So what is your interpretation of height? Does this child have short stature?
Yes, sir.
What's the definition of short stature cross-sectionally?
When the height for age is less than 3rd centile for age, sex, and population, or the
In terms of Z-scores?
height for age is less than minus 2 standard deviation.
Excellent. So the criteria is satisfied. In terms of discrepancy from the target height, how many percentile lines below should you have to label this child as short stature?
2 percentile lines below.
In terms of Z-scores?
In terms of Z-scores, at least 2 standard deviation below the target. height.
Yeah. So does this child 1.5? Some references would say. So does this child satisfy the target discrepancy from the target?
Yes, sir.
So the target height is at minus 1.3.
Minus.
The child's current height is at minus 3.3. So there is a minus 2 standard deviation difference versus the target height. So this is a very, very important percentile. So what do you mean by percentile?
Percentile is the, for example, if the child is in 50th percentile, it gives you a meaning that there are 50 other children belonging to that height above that child and below that child.
Very good. It tells you the relative position of the child in the perspective of the age and sex matched population. A child at the 50th percentile at the 50th rank in an ascending order of 100 children. A child at the 3rd percentile is at the 3rd position from bottom in an ascending order from 0 to 100. So it tells you the relative position of the child in terms of the age and sex matched population. And in terms, what does Z-score tell you? What does it tell you? What do you understand when you say that child's height Z-score is minus 3.36 standard deviations away from the mean?
When the child's Z-score is minus 3.36 away from the mean, it means that the child is so much, it is 3 times negatively deviated from the median.
Excellent. So it is the sign and the value. Both of them have a very, very important concept. The negative sign tells you that it's on the negative side. The positive sign tells you it's on the positive side. The more higher the number, the more deviant is the child away from the population. So a child who has minus 2 standard deviation has short stature. A child who has minus 3 standard deviation has severe stunting. So the more deviant the child is, the more likelihood of finding an abnormality, the more likelihood of a pathological state. And if you see in this slide, there is a slight dichotomy in terms of your assessment. If you see your height Z-score, it seems to be significantly discrepant. But whereas when you look at your weightage and heightage, it gives a perception that weight seems to be affected more. So do you want to comment on that? Which do you think is more robust? Do you want to rely on Z-score or you want to rely on heightage, weightage?
Z-score has more reliability than...
Excellent. So I think Z-score is an objective parameter to really objectively define the relative position of the child in the perspective of the population and tell you which is more affected, whether height is affected or weight is affected more. Weightage and heightage are surrogate markers of your Z-scores. But with the statistical manipulations and non-parametric nature and the combination of different charts that are being produced, I think the heightage, weightage takes a slightly lower position in terms of reliability when you compare with the Z-score concept. So to just complete it, so you define what is short stature, what is tall stature.
When the height for age is more than plus 2 standard deviation for age, sex, and...
Very good. What do you mean by, what do you what do you want to label this child's BMI as?
BMI...
Normal.
Normals.
Yeah. Go on. Next slide.
So this is the growth chart which I have plotted for this child. So as you can see, the weight of the child is below the 3rd centile and the height of the child is below the 3rd centile. I have also marked the height age and weight age of the child. So that is marked by drawing a horizontal line from the plotted weight and to the 50th centile and by drawing a vertical line downwards from there. So the corresponding age where the vertical line drops is the weightage or heightage of the individual. So for this,
for simplistic understanding, what do you define heightage as?
Heightage is the age at which the current weight of the child is at the 50th percentile, sir.
Very good. It matches with the 50th percentile of the corresponding age and sex. And this slide you can very beautifully see that there is a discrepancy between the child's target height percentile and the relative position of the child on the growth chart. Significantly discrepant versus the target height. What is the name of this chart you have used here? I really did not notice previously. What is the name? This is the combined IAP. Yeah.
Extended IAP growth chart.
Very good. It's an extended IAP chart. What is the concept of extension? What has it extended into?
It has additionally has Z scores along with the centiles. which includes minus 2.25, minus 2.5, and minus 3 standard deviation score along with the sentence.
So if you're looking at a scenario where you're not able to calculate z-score, plotting on this chart, you really know that your child's height is 3 standard deviations away from the mean. You're looking at a child who has significant pathological stunting to relatively tell you that this child has a significant cause of short stature. Now, based on the growth chart, if you want to distinguish whether this child has a normal variant or whether this child has a pathological cause for short stature, looking at this growth chart, can you, and of course the previous table, can you give me some clues to tell me whether this child has a pathological cause for short stature or does this child have a normal variant?
Pathological cause of short stature, sir, because
Why?
the child height is less than 3 standard deviation for his age, sex, and
Very good. The child is significantly discrepant, 3 standard deviations away. That puts the first possibility as the cause for pathological cause. Second thing, very beautifully in the last slide, you pointed out that the BMI is relatively normal. So a preservation of BMI in a child who is pathologically short really alerts you to a possibility of an underlying disorder. And of course, subsequently, you also discussed about serial growth tracking. And when you find that the growth tracking shows a significant dip, you know that this child has a pathological cause and you cannot ignore. So just on the basis of growth chart, such a valuable, inexpensive tool, which clearly told you don't just sit tight, look at this child more carefully. This child is not something who has a normal variant and can be observed, but needs to be looked into very carefully. Thank you so much. Go to the next slide. So this is the growth. Yeah, go ahead.
1 second, sir. Okay. So this is the from the IAP app. After entering the child's height, weight, and parent's height, we get a direct image of all this height for age percentile along with the Z-score with it. So this child's height for age is lying below less than third percentile, which also tells us the Z-score along with it, which corresponds to minus 3.36. And child's weight for age is again less than third percentile with a Z-score of minus 2.54.
Yeah, thank you. Seema, can you rattle out how did you measure the height of this child? Just rattle in 2 sentences.
Yes, the child was made to stand in a stadiometer. The child is made to stand with 2 feet apart with back. I mean the pointers of contact touch in the walls or occipital protuberance, shoulder blade, buttocks and calf, and the
5 points, isn't it? 5 points, isn't it?
occiput, shoulder blades, buttock, calves, and the heel, sir.
Very good.
And the child's face should be in such a way that the Frankfurt plane is parallel to the ground. And while seeing the height, the examiner should see the calibration parallel to the measurement. And if there is any braid or hair bands, which it has to be removed while checking the height.
Excellent. Can you just rattle out how did you measure, if at all this child was a young child, how did you measure the length?
We have to measure the length using an infantometer. We need 2 examiners preferably for seeing the length of a child. The infantometer will have a fixed headboard and a mobile footboard. The child's head is held by 1 examiner along the fixed headboard, and the child's knee should be slightly extended with foot firmly placed upon the mobile footboard, and the length should be correspondingly taken with the nearest.
Very good. With a gentle pressure on the knee, with the gentle pressure obtained, pushed against the length and the footboard. And what about the plane? The vertical Frankfurt's plane. You know, your Frankfurt's plane should be perpendicular.
Perpendicular to the horizon.
I request all the audience to read the WHO manual and the Intergrowth 21 manual, which very beautifully describes the procedure which clinicians should adopt while measuring length, while measuring head circumference, while measuring weight, while measuring height. Very beautifully standard protocols have been described as to how one should measure. Just to complete, what is accuracy, what is precision of measurement? accuracy is having the measurement on a similar platform when you compare it with a gold standard examiner. Suppose I am the gold standard examiner, and if my measurement is 50 and your measurement is also 50, then your measurement is accurate. A precise measurement is one which has a good repeatability. Today morning I measured it as 50 centimeters length. Today afternoon I measure it as 46 centimeters, and today night I measure it as 42 centimeters. That means I am an imprecise person. My measurement is imprecise, or my infantometer is imprecise. A good clinician should have both an accurate and a precise measurement to be done. Okay, next slide.
The same app will also tell us the BMI for age, which lies between 25th to 50th percentile with a Z-score of minus 0.20.
Excellent. So just to complete, what does this the orange line and the black line indicate for you?
Orange line indicates when
23rd adult
third
age.
equivalent BMI, and blue line indicates the 27th adult equivalent BMI.
And what does the green line indicate at the bottom?
Third percentile.
Third percentile. What overweight, obesity, and what would you call somebody's BMI below third percentile as per the current IAP terminology?
Thinning, sir.
Thinness. Very good. Okay. And what do you mean by extended BMI charts?
Extended BMI charts will also include class 2 and class 3 obesity above the 23rd and 27th adult equivalent lines.
So what is class 2? What is class 3?
More than +2 standard deviation and more than...
No, it's not +2. See, +2 standard deviations is not true. So it is more than, your equivalent of 35 kg per meter square, your 23, 27, 35 and 40, or it is more than 120% or 140% of the equivalent of the BMI of that particular age. Extremes of BMI. You have an extension of height which was done in the extended growth charts which you showed previously. Extended BMI is an extension of the BMI above to identify class 2 and class 3 obesity. Very good. Go on.
So we also calculated the height velocity for this child using the height at 5 years 1 month, which was 93 centimeters, and height at 5 years 8 months, which was 95 centimeters. So of 2 centimeters over 7 months and at around 4 centimeters over 1 year. So in this height velocity chart, we have to plot it between the two time. This center point should be taken between the two time frames, which is between 5 years 1 month and 5 years 8 months. I approximately plotted at 5.5 years. The height the y-axis measurement corresponds to how many centimeters the child had grown between these two timelines, which is 2 centimeters.
No. I think Madam just pointed that out. You have to calculate it as the annual growth velocity. So it would be 2 centimeters over a period of 7 months. So that would extrapolate to 4 centimeters per year. So you would plot the y-axis as 4 and the x-axis as 5.5. And definitely, yes, it is below the 25th percentile. So growth velocity below what percentile alerts you?
Below 25th percentile for over 6 months to 1 year.
Growth velocity above what percentile alerts you?
More than 97th centile.
Usually 75th. 25 and 75 is taken as a cutoff. And what is the minimum age you can plot growth velocity on?
5 years.
Yeah, the chart says 5 years, but technically speaking, 5.5 years is what you would be able to plot on. Next. So this child has all the 3 criteria. So what are the 3 criteria for short stature, and what are the 3 you have identified on the growth charts? Can you just sum it up?
We have a height for age less than 3rd centile.
Or Z-score, in terms of Z-score?
Or minus, less than -3 standard deviation.
Height is below -3 standard deviations, number 1. Number 2?
Number 2 is height velocity less than 25th centile for a period of 6 months.
Number 2. And versus target?
2 standard deviation below the target height.
So 1.5 to 2 standard deviations below the target. So all the 3 criteria for short stature you have proved on the growth charts. Next.
Upper segment and lower segment ratio. So the lower segment was obtained from the upper border of superior border of pubic symphysis till the feet of the patient, which corresponds to about 46 centimeters. and lower segment. This is lower segment. The upper segment is obtained by subtracting lower segment from the total height, which corresponds to about 49 centimeters, and the ratio comes out in about 1.06:1. So when plotted in upper segment is the lower segment chart at around 5 years, 7 months, it approximately corresponds to 50th centile.
Very good. So suppose the value had gone above the 97th centile, what would you have labeled it as?
Short trunk.
Above the 97th percentile. So that means the child has a very high upper segment. So what is the lower segment?
Short limb, which means
Yes.
short limbs.
Suppose if it had come below the 3rd percentile, what would you have done?
Again, it corresponds to very short trunk.
Very good. How will you subclassify short limb further?
As acromelia, rhizomelia, and mesomelia, sir.
Okay. And you would be able to rattle out the cause for one of them in everything? You would be able to say it? In any standard textbook, you would be able to read that. Just for completion, say it off.
So mesomelia, the Shox mutation or mesomelic
Okay.
dysplasia. Rhizomelia, we have Ellis.
No, rhizomelia commonest one. What do you see? Paternal age you just discussed.
Achondroplasia, yes.
And distal?
Distal, again, Ellis-Van
Ellis-Van syndrome. And short trunk?
Mucopolysaccharidosis.
Very good. Go on. So this chart gives you an objective evidence to go in for more complicated evidence like, skeletal survey, doing so many x-rays, going for an expensive genetic test. So this chart will be kind of an objective proof to convince the parents to take up those diagnostic modalities. Go on.
So this is how we calculate the midparental height. By convention, it is we measure father's height plus mother's height plus 13 in male child and minus 13 in female child, whole divided by 2, which corresponds in our case of about 162.5 centimeter. And from that midparental height, we should calculate the target height, which is plus or minus 6 centimeters, which corresponds to about 156.5 centimeters to 168.5 centimeters, which lies within 3rd to 10th centile. We can also calculate the midparental height easily in this IAP growth chart with a simple MPH calculator, where we have to put a dot in father's height along the left longitudinal line, and mother's height should also be plotted. And connecting these two dots will tell you under what centile the midparental height lies upon.
It may mention one advantage and one disadvantage of this midparental height calculator.
Advantage is it is easy and quick tool to identify without any calculation, sir.
Disadvantage?
Disadvantage, it will not say the target height range, and it will not also be useful in very extreme heights.
Yeah, a very tall man marrying a short lady. A short man marrying a tall lady. Vice versa, this is not going to be helpful because that's going to be an inaccurate tool. Okay, very good. Go on. So old is gold. Midparental height by the conventional calculator stands true. This is just a screening tool to complement it.
Okay. So this is, I calculated BMI. By convention, it is weight in kgs divided by height in meter squares. In our child, it corresponded to about 14.4 kg per meter square. When plotted in BMI chart at around 5 years, 7 months, when plotted at 14.4, it comes between 25th to 50th centile. So we also have something called as BMI lookup tool, which is only used in children more than 8 years, where it is a very easy tool. We just have to connect the intersecting point between the height in x-axis and weight in y-axis, and it will easily classify for us whether the child lies in underweight, overweight, or obese.
Very good. So again, list one advantage and one disadvantage of this BMI lookup.
Advantage, it easily classifies whether the child is coming in underweight, overweight, obese, sir. But disadvantage is it will not classify under which forms of obesity if in case they...
Yeah, it makes your work easy, no manual calculation. So advantages, disadvantages, it's not a very validated tool. And number two, you can use it only above 8 years. Okay, go on. So you saw the array of tools, and from this anthropometric measures, what are the key positives you want to tell me?
The child is having severe short stature, sir.
Severe stunting. because a child's just to complete it. Why is short stature and stunting synonymous?
Um,
I think
Stunting
you
is
answered that previously correctly.
more of a community term, whereas short stature is more of a clinical term that we use in that.
Very good. See, I think yes. So short stature is a diagnosis which is offered to an individual child in a clinic setting. Stunting is something which is offered in a community setting to mass survey. Though both are replaceable, I think the context in which it is used is what you have to keep in mind. So height below -2 standard deviations. This child has height below -3 standard deviations. Yes, number one.
With a relatively BMI is with a relatively
Relatively preserved. Very good.
um,
Versus target.
below, I mean, less than his height was below the target centile, sir.
Significantly below the target centile. So anthropometry has given you such major valuable clues. Now quickly go on to physical examination and tell us what you really found as positive.
Okay, head to toe examination. Normal, sir. No frontal bossing or dysmorphism. Eyes, nose, ears were normal. Dentition and oral cavity normal. There was no midline defect seen. No webbing of neck. Shape of chest was normal and no skeletal deformities. Forearm, arms, and hands normal. No goiter, coarse species, edema, and calf hypertrophy.
So why did you
You
look
mention
for
any
all of them?
abnormal dentition related to short stature?
Single central incisor in growth hormone deficiency, ma'am, and in
Sorry?
single central incisor and growth hormone deficiency.
Very good. Anything else? In hypophosphatemic rickets, which can present with severe stunting, you can also have dental abnormalities, and that may give you a clue for a possibility of metabolic bone disease. And osteogenesis imperfecta, which you brought out in the history, bony deformities and recurrent fractures, they can have a dental component, and you can have a dentigerous imperfecta component of the osteogenesis imperfecta.
Okay, sir.
Go on. So, what are the clues for Turners you looked for? You say.
Any low posterior hairline, webbing neck, shield chest, any cubitus valgus, any distal radial deformities.
Very good. Did you look up the fundus of this child?
Yes, sir.
So what abnormality did you look for?
We have to look for any increase in papilledema has to be looked for. Rule out any increased intracranial pressure signs, or any in metabolic diseases, we have to look for cherry red spots.
Okay, fine. Go on.
Skin hyperpigmentation in lower limbs, probably due to insect bite allergy. Hair and nails were normal. No asymmetry of body noted. External genitalia was normal with a
What
stretch.
did you think when you thought of asymmetry of body parts?
Hemihypertrophy in silver Russell syndrome, sir.
Very good. Okay. And genitalia you found out were normal. So what genital abnormalities did you have in mind when you looked into the genitalia?
The child can have micropenis and growth hormone deficiency. And
cryptorchidism as a part of the hypogonadal component of hypopituitarism. And if this child had hard of hearing, what would come to your mind?
Pendred syndrome, Turner syndrome.
Okay. I mean, this is a boy child. Pseudohypoparathyroidism also can come. Okay. Okay. And so this child has a prepubertal tanner, isn't it? Prepubertal tanner.
Tanners corresponding to prepubertal stage.
Suppose this child had very large testes, what would you think of?
Precocious puberty, sir.
Due to? See, precocious puberty is associated with tall stature. Short stature with precocious puberty is hypothyroidism. You already have hypothyroidism in the background, isn't it? Large testes. Your TSH behaves like FSH and causes growth of the testes, but there is no growth spurt. Okay, go on.
Systemic examination, abdomen was soft, non-tender, no organomegaly. Cardiovascular system, S1, S2 heard, no muffling of heart sounds and no precordial bulge. Respiratory system, normal vesicular breath sounds heard. And CNS examination were normal with normal tone, power, and no calf hypertrophy or visible wasting. Deep tendon reflexes were normal, sir.
Very good. So you have specifically mentioned the neurological features of hypothyroidism, cardiac features of hypothyroidism, which you probably wanted. Did you palpate the femorals?
Yes, sir.
Yes. So they were normal, isn't it? Okay. Very good. Go on. Can you summarize this case?
So this is a 5 year, 8 months old school-going boy child, first born to non-consanguineous parents with uneventful birth history, born appropriate for gestational age, presented with progressive short stature, noticed since 3 years of age, with slow growth rate and relative affection of height more than weight, with normal development, dentition, scholastic performance, and with no significant chronic systemic illness. Under regular thyroxine supplements for past 7 months, with no family history of short stature or delayed puberty in parents. On examination, child was found to have proportionate pathological short stature with underweight and severely stunted, with height more affected than weight, and with height velocity less than 25th percentile, with a normal genitalia with no dysmorphism and no skeletal abnormalities.
Very good. So you have highlighted all the major points. So what are the differentials you would like to consider based on this?
Differentials are initially to rule out endocrine etiology such as isolated growth hormone deficiency in hypopituitarism and hypothyroidism, constitutional delay of growth and puberty, and chronic malnutrition.
Yeah, so I think these are the differential diagnosis. So can you list the points for and points against? Yeah,
Points favoring growth hormone deficiency endocrine causes are the child is severely stunted with Z-score less than 3 standard, -3 standard deviation, with a height velocity less than 25th percentile. The points against are the child is also underweight with no history of any neonatal hypoglycemia, seizures, or midline defects, with a normal genitalia. For hypothyroidism, the points favoring are same. The child is severely stunted with less than 25th percentile height velocity, with normal FT4 and absent goiter.
so
Points
probably we can also add that child did not have a spectacular growth response when thyroxine was started. It did not really make a difference in terms of the growth, catch-up growth. Okay.
Points favoring malnutrition is the child's weight for age is also affected with mild pallor present. Points against are again severe short stature, velocity is height velocity less than 25th percentile, and BMI with a normal percentile. Points against the constitutional delay of growth in puberty is the growth velocity is very low, and there is no family history of delayed puberty.
Right. Very beautifully, you have summarized the pros and cons. So over to Madam on evaluation of this case.
Before you proceed to evaluation, one small question for you. Hypothyroidism causes what type of short stature? Proportionate or disproportionate?
Hypothyroidism, no?
Yes.
Proportionate short stature, no?
Can it cause, normally it causes proportionate. Can it cause disproportionate? Yes, no. It can cause. It can cause short limb, short stature also when it affects the growth plate. It can. Not, but as a rule, it generally causes proportionate short stature. Can you tell another cause of short limb, short stature? Quite cause, apart from whatever you mentioned.
Um,
Common, which you wanted to ask you in your history also, you asked sunlight exposure,
the deficiency.
rickets. Rickets causes short limb, short stature. Yeah, you go for your evaluation.
Sir, sir, any questions, sir?
No, 2 or 3 comments. One, Madam asked about high paternal age. High paternal age may be associated with a few syndromes. Just for exam point of view for the students. One is Marfan, of course, tall stature, right? You can have Eppert syndrome, like acrocephalosynactally, one of the craniosynostosis thing, and Marfan's, Ebert's, and your Klinefelter syndrome can also occur in high paternal age. Even incidence of Down syndrome is higher in high paternal age. Last but not the least, Engelmann syndrome, the one which is associated with psychosocial problems with the psychiatric disturbances. These are all some of the conditions which, other than achondroplasia, these can be associated with high paternal age. And the other important point that in the examination, You said that the teeth dentition is normal. This child is 5 years old. What do you mean by normal dentition of 5 years? Can you answer my question? What is normal dentition at 5 years?
Child will have all primary tooth, sir.
How many? How many?
Scissors.
At 5 years, how many you expect? That's my question. Fundamental pediatrics.
Central incisor, lateral incisor. We'll have
20, man. 22, 1, 2. 20.
20.
You expect the child to have 20 at 5 years, right? So you could have mentioned the number.
Okay, sir.
Instead of saying normal dentition, as a general pediatrician, I would expect you to tell me the number of teeth. And also mention specifically that there are no abscesses, okay, and there is no abnormality in the shape of the teeth, indicating that you look for some other clues for enamel hypoplasia and abscesses, etc.
Okay.
Right, and easy to remember. Most children have 20 teeth at this age, and before 7 years, you don't get fall of teeth. You don't
Yeah.
get fall of teeth. Okay, that is regarding dentition. Suppose if I were to ask you, you have put 4 groups here, right?
Yes.
Is there any other possibility other than all this? Fifth one I would have included. What is the fifth one? Not belonging to any other. See,
Yeah.
fifth group, because not common. Okay, I'll tell you which group. I think I would have definitely thought of some chronic disease,
Systemic illness.
non-infectious. See, it's not if it's not a sick child, okay, and in a child like this who has got some problem of a combination of both involvement of height and weight, you should think beyond endocrine causes and think beyond malnutrition. And nowadays we must all remember, even in children's hospital, what you see as malnutrition. Somebody is putting in the chat box quite rightly, celiac disease, quite rightly. In fact, at some point, I would have wanted to know from you, what is the religion of this child? And the origin, ethnic origin of this child. If this child, you had told me that they are from, North India, Rajasthanis, or somewhere close to Pakistan borders, then the other possibility I would have thought of is celiac disease and the malabsorption, which can produce a combination of growth failure, as well as malnutrition. And you said the child was quite okay until 3 years, right?
Yes.
So that is another possibility. Any chronic gastrointestinal cause, you should have thought of. In fact, I would have put this whole problem with, because Dr. Hemchand and Sridevi are taking this, you said it's an endocrine case. I would have said this is failure to thrive, because there is short stature and also some affection of the weight. So both are affected. By definition, to me, this child is failing to thrive. And any failure to thrive, you should look at causes which cause too little in, too much out, and too much is required, or too little is utilized. One of the categories, and in this category, I would have thought of causes beyond endocrine, beyond skeletal, into GI causes, systemic gastrointestinal malabsorption, etc. And sometimes you can get a combination also, so-called IPEX syndrome, where you can have hypothyroidism along with chronic diarrhea, gastrointestinal causes, etc. And last but not the least, for the child were to be ill-looking and is suffering from frequent hospitalizations, one of the things you should always think of is immunodeficiency resulting in all this. All this can happen. Malnutrition, growth hormone, as well as the thyroid issues will all be part of systemic disease, chronic systemic disease. Okay, these are my thoughts. Excellent discussion. Thank you.
Thank you. So investigations, the tier 1, tier 2, and tier 3 investigations are tier 1, we look for a basic CBC with RFT, liver function test, calcium, phosphorus, and alkaline phosphatase, thyroid, urine, and X-ray hands and wrist, stool for ova and cyst. Tier 2 investigations, we have to include serum tissue transglutaminase, IGF-1 and IGF-BP3, karyotyping in case of any female child. Tier 3, we have to go for a growth hormone stimulation test and MRI brain. So in this child, in CBC, HB was 9.1, suggestive of microcytic hypochromic anemia. FT4 done was 1.13 and TSH was 3.829. RFT, LFT, calcium, phosphorus, ALP were normal. Urine protein was normal. Serum trans PTG IgA was normal. Ultrasound thyroid, anti-TPO, anti-TG was done to rule out any autoimmune thyroid. IGF-1 corresponded to -2 standard deviation score with a normal serum cortisol of 12.1 mics per deciliter. And then we proceeded with, since this was such
You
a
go to the previous slide, 1 minute, Asima. You mentioned, here I would just like to differ with you on that, since your first diagnosis itself is one of the first and second possibilities, endocrine. So your growth hormone stimulation and MRI brain may come as tier 2 rather than tier 3. That's okay. Even that is what the standard treatment guidelines recommend. That's okay. Next slide. In this slide, you have mentioned serum TTG and IgA. Why do you want to do both? What is the implication?
In case of any complete IgA deficiency, the serum TTG IgA can give you low levels, which can lead you to a false negative value, ma'am. So if that,
Yes.
we have to
Just
always
if the TTG is absent, you cannot conclude that celiac is ruled out. In the presence of IgA deficiency, it may still be absent. So you should ensure that the IgA level is normal, and then serum TTG should be undetectable. Only then you can say that you have sort of ruled out celiac. Okay.
Very well said. The correct order is IgA and then a serum TTG. That should be the order.
Okay, sir.
Okay.
So the indications in this child to go for a growth hormone stimulation test was the child's height was less than third centile with a standard deviation score below 2 to 3 standard deviation, height velocity less than 25th centile over 6 months, and Z score was below 1.5 of the midparental height Z score and absence of any familial and constitutional causes. So before going for growth hormone stimulation test, the child was kept overnight fasting for at least 8 hours. We ensured that the child was euthyroid, cortisol was normal, and anemia was corrected.
Yeah, very good. So that's what I wanted to ask you in the previous slide. What is the purpose of doing the cortisol? One important purpose is you should ensure that it is normal. So thyroid function also, you should ensure that it is normal before you do the growth hormone stimulation test. Okay. What was the hemoglobin you said?
It was 9.1, mum.
Because
On,
clinically you had noticed pallor.
yes, ma'am.
Okay.
And further proceeded with growth hormone stimulation test. We initially did with oral clonidine with a dose of 0.15 milligram per meter square, which showed values at 30, 60, 90, and 190 minutes. And 48 hours later, we also did with subcutaneous glucagon, which also showed all values corresponding to less than 5 nanogram per ml. During this time of stimulation, the child was continuously monitored for any hypertension and hypoglycemia. There was no signs of hypertension and hypoglycemia, ma'am. And
Why
MRI,
did you do twice?
ideally, we have to do with 2 stimulating agents to confirm growth hormone deficiency.
And you improve the specificity of the test.
Yes, sir.
Can it be done with one in any conditions? Can you do just one?
With any clinical clues pointing like any previous history of cranial irradiation, infections, tumors?
Okay. In the presence of intracranial lesions, in the presence of genetic defects, and in the presence of multiple pituitary hormone deficiency, one stimulation test is enough. If it is going to be pure growth hormone deficiency, you need 2 stimulation tests. Okay. What all can you use for stimulation test apart from your clonidine and glucagon?
We can use insulin, arginine,
Yes.
L-dopa
Yes.
hormone, and also
Okay.
GHRH.
And GHRH also you can use. Growth
Yes.
hormone releasing hormone. Okay. MRI, what is that you look for?
We have to look for any intracranial tumor structural defects, pituitary adenoma structural causes.
Okay.
And,
Go ahead.
so for this child, we
So
initiated
what is that you have implied with your investigation? What is that? What is your interpretation?
the stimulated growth hormone is less than 5 nanogram per ml, which implies complete growth hormone deficiency.
You mean to say it's a isolated growth hormone deficiency with pituitary being by imaging wise normal and all the other investigations being normal. Now out of your 4 differential diagnosis, you have narrowed down to 1 with your investigation. Okay. Over to Hemchand.
Yeah, thank you, ma'am. I think like a jigsaw puzzle, it is kind of fitting in. She started off with a child who began to falter at the childhood onset of phase of the ICP model. The history and the physical examination, the relative position on growth chart led her to a possible diagnosis of an endocrine cause. Though there was a background of thyroid disorder, the most of the pointers were towards a growth hormone deficiency. And corroborated with the skeletal maturity, the biochemical testing has led her to a possible diagnosis of growth hormone deficiency. Rapid fire, you have put very beautifully the growth hormone treatment which you have given. Giving growth hormone to a child with growth hormone deficiency, what is the oxological benefit that you get?
The height will increase in initial for 1 year to around 8 to 10 centimeters.
Okay.
Later on to around 6 centimeters, and then finally to 4 to 5 centimeters.
What is the dose of growth hormone?
25 to 30 microgram per kg per day.
Of daily acting growth hormone or weekly?
Weekly, we can go for 0.45 to 0.65 mg per kg per week, sir.
0.66. What is the route of administration?
Subcutaneous route.
Site of administration?
In thighs, arms, abdomen, and buttocks.
Any subcutaneous injection. What is the youngest age you can give growth hormone?
You can give at 2 to 3 years in case of any SGA who failed to catch up, or any in infancy also we can do if they had neonatal hypoglycemia associated with
Even with a newborn, you can give. And what are the side effects? Can you list out the side effects?
fluid retention, edema, signs of any increased intracranial pressures, pseudotumor cerebri, nausea, vomiting, worsening of scoliosis, gynecomastia, hypoglycemia can also be a side effect, and also slipped capital femoral exercises.
Hypoglycemia, little uncommon. Okay. What are the causes? So, when you follow up a child on growth hormone therapy, what are the things you would like to follow up this child for?
I should regularly look for growth velocity of this child, sir, over a period of 3 to 6 months. And for every 6 months to 1 year, I have to follow the insulin-like growth factor 1 levels. We have to make sure that IGF-1 level is below the upper half of higher range. That is on 50th, less than 50th centile.
Okay. And you would also have a look into the fundus. You also look at the injection sites, isn't it? If there is poor response, what would you do?
If there was poor response, we have to first initially check for the complaints, whether the complaints is good, if their mode of giving injection is right.
The dose is adequate.
Dose is adequate.
Other pituitary hormone defects have been covered. And
Yeah,
this, most
like
importantly, is your diagnosis right?
Right.
When would you stop growth hormone?
When the height, increase in height is less than 2 centimeters in a year. And,
Bone age is more than 14 years in a girl and 16 years in a boy. They have become an adult. There's no point in giving growth promoting treatment. Can you list about 5 non-growth hormone deficiency indications to give growth hormone?
Noonan syndrome, Turner's, Shock's gene mutations, skeletal dysplasias, and poorly
Right, very good. So name one skeletal dysplasia which can recently be treated.
achondroplasia with vosoritide, which is a
Very good.
fibroblast growth
So
factor.
we've discussed about this particular treatment. So other particular treatment conditions you are quite aware of. So how would you follow up this child?
Yes. Every visit, we have to check for any injection site issues, monitor for any side effects. Weightage and height velocity has to be seen once in every 6 months. Bone age assessment has to be done once in a year, and IGF-1 levels has to be maintained on 50th centiles.
Very good. And periodically you would also screen for other pituitary hormone defects.
Other critical hormones.
This child may develop cortisol hormone deficiency tomorrow. Child may develop sex hormone deficiency day after tomorrow. Child may develop diabetes insipidus at some point of time. So those things you will definitely have to screen them up for, isn't it? So
Okay.
before, so that's how you would follow up this child. A quick rapid fire. Define SGA.
Small for gestational age is birth, weight or length less than 10 centile for that gestational age, sir.
Or -2 standard
And
deviation.
it's a standard deviation.
Okay. Name any 3 syndromes who have a special growth chart.
Downs, Turner's, Prader-Willi,
Excellent. Z score 0 is equal to dash percentile.
50th percentile.
Very good. And your best method for bone age to be done in day-to-day practice?
Brulish tiles atlas.
It's a practical way. Ideal way would be a Tanner Whitehouse method. And what is the treatment of choice for constitutional delay of growth and puberty?
Actually, only reassurance. We have to start with the treatment in a male child, only with any psychosocial distress, sir.
Okay.
If
Very good. You will give a short course of sex hormone treatment. Name 2 conditions for silent short stature.
celiac disease, chronic kidney disease,
Name 2 systemic diseases which can be treated with growth hormone. We discussed that. Thalassemia with an
thalassemia and
with hypopituitarism and chronic kidney disease who fails to catch up with all routine measures, isn't it? So before, madam, do you want to add anything or shall I go ahead with the take-home points?
Yeah, you can go ahead, Hemchand.
Yeah, so before I wind up, just we are summing up the take-home points. Before that, for all postgraduates who are attending, there are STG guidelines on short stature which can be looked into. In IJPP, madam is a part of the editorial team. There is a very nice article on recent concepts in growth chart and growth monitoring. IAP Growth Monitoring Guidelines 2007 is there free for download. Indian Pediatrics. All of you must be familiar and read and know the referral criteria and the definitions. And there is a recent article by Riddhi Patel in Indian Journal of Pediatrics, Approach to Short Stature based on Z scores. A very simple and a useful article. So I'm just summing up with the take-home points. Number 1, all of us, whenever we are reading and managing children with short stature, please remember the IAP Growth Monitoring Guidelines 2007. They became way back in 2007, but they are very much applicable even today. Please use the WHO charts modified by IAP in the first 5 years of life and IAP 2015 charts above 5 years of age. The simple rules of growth chart monitoring and plotting should definitely be followed in terms of keeping a dot, calculation of target height, marking, connecting the dots, etc. Standard definitions recommended by WHO and IAP should be used to define growth abnormalities: stunting, severe stunting, short stature, pathological short stature, overweight, obesity, low growth velocity, etc. The newer tools are very useful in children for convenience, but old is gold. BMI lookup tool and MPH calculator are newer tools, but still conventional calculation of BMI and conventional target height calculation should be used in the exams. And adjunct tools, growth velocity chart and Indian proportion charts should be used as appropriate to identify short limb, short trunk and low growth velocity. ICP model should be used to identify the timing of growth faltering and likely pathological cause, whether it occurs during the infancy phase, childhood phase, or the puberty phase. Normal variants should always be considered, and pathological causes should be distinguished from normal variants. I think growth chart remains the most valuable tool to help a clinician distinguish between a normal variant short stature and a pathological short stature. The IAP growth chart app should be used to calculate Z scores and identify children who have short stature, pathological short stature, and serially monitor the growth of the child and keep it on a permanent record on cloud, and serial tracking of growth on a growth chart, serial tracking of Z scores, and whenever you see upward shift or downward shift in any growth parameters that occurs very rapidly, in terms of percentile lines, 2 major percentile lines, in terms of Z scores, 0.67 Z scores should always be viewed with caution. I think these are the 10 take-home points which I thought we should remember in every child with short stature. Thank you very much to IAP-CCB for the valuable opportunity given to us, and special thanks to Sridevi ma'am, and special thanks to Dr. Asima, who put up with all the non-stop corrections we kept on giving for the past 3 days. Thank you so much.
Thank you, sir. Thank you
Seema,
so
I
much.
would just like to conclude with just one point. Word of caution about the growth velocity chart. It's a very important height velocity chart. It's an important chart. But remember, the height velocity takes into consideration only the age and the gender. But one problem with this is the onset of puberty. The onset of puberty may vary in different children, and the height velocity may also vary depending on the stage of the puberty. So that we have to keep in mind rather than the generalization. But definitely the methodical approach works. So whenever you encounter for this pre-adolescent child, it is okay. But whenever you encounter a child between 8 to 12 years of age, you should also consider the stage of puberty the child is in to interpret whether the child is in the appropriate height velocity. Thanks, IAP-CCB, for the opportunity.
Thank you so much, ma'am. Thank you so much, sir, I had a very nice learning experience while doing this. Thank you.
Thank you, sir. Thank you, Hemchand, sir. Thank you, Sridevi, madam. Actually, Dr. SB sir has to leave in the middle. He has commented that the discussion was very brilliant, and the PG has done exceedingly well. Actually, it was a learning point for us also. Usual teaching is short and plumpy. It is endocrine cause. So here the child was not plumpy. So we had a discussion in that way. So it is not a plumpy child. And the SBS sir brought out how you have to tell in the history that the other causes has been ruled out. Even though sometimes in the examination, most of the PGs, they know the case. The child would have been under follow-up with us. So they will know the case, but you have to present to the examiner, final exam, you have to present to the examiner as if you have derived something from the history, and show off that it is endocrine cause. That is what SB sir was trying to say. So you have to rule out other causes from the history, and sir brought it out very well. And excellent discussion by Dr. Hemchand sir in between about the growth charts, all the aspects of the growth charts, and finally, Madam concluded well about bringing about all the other causes also. I think you have thought of celiac disease, that's why you have evaluated, but you have not put it in that. So sir was expecting celiac disease. Very thoughtful, good discussion. So I thank one and all. Dr. Somsundaram sir, any comments?
Hello. Hello.
Yeah, we can hear you.
Am I audible, Prasanna?
Yes,
Yeah.
sir. Yes,
So,
yes, sir.
So it was a wonderful discussion. So we reached more than 70 participants at any time in the Zoom platform, and more than about 30, 40, 20, 30 YouTube viewers. So it was an excellent session, because endocrinology, as you know, it's it's very very practically it has to be learned, and it can't be learned like in books like other things. And both the faculty people did well, and such SPSR was also very complimenting both their views. And Azima, you did a good job with the tutoring of Prasanna. So thank you for yet another session, and thank you Sridevi and Hemchand for your time. This sparring and mentoring our postgraduates, not only Azima but all the people who are there on YouTube, and people will be following it on YouTube, because there are already few queries whether this will be on live on YouTube or it will be available on YouTube. The same link it is still it will be available for years long together.
You can view it in the all the discussions, previous discussions also. You can view it in the IAP CCB YouTube channel.
Yes.
I also thank Dr. Balaji and Dr. Ramya, our in-house endocrinologists.
Be with the Zoom platform for about for the past 1.5 hours. Thank you very much, Prasanna. Thank you.
Thank you, sir. I also thank Dr. Balaji and Dr. Ramya. They are our in-house endocrinologist for preparing this case with Azima. So I thank all the participants, audiences for staying here so long. Once again, I thank all the moderators and the presenter and Dr. Som Sundaram sir and Dr. SBS sir. So I think with this we'll end the meeting.
So before we conclude, request all the postgraduates to register for Marina Pedicon. So we have the same Parthasarathi award and the subsequent poster presentation, and wonderful PG sessions are also there. So request all. Prasanna, you can share the thing with your postgraduates.
Sure, sir.
Okay. Yeah. Sure.
Thank you. Thank you.